Over the next 30 minutes or so, I'll be covering these four major points, really. The selective immunisation programme for pregnant women, what stages in pregnancy, an overview of the diseases that we vaccinate against, and if there's time, we'll have a look at some of the trusted sources of information. If you've been to my stand or my organisation stand out there, you'll see that we've got all sorts of literature, one of which is the selective immunisation programmes. And you can see here that for pregnant women, there are 3 vaccines that we routinely offer now in pregnancy, the first of which is influenza, and the inactivated influenza vaccine. There are different types. There is a live vaccine, which we don't offer to pregnant women, but there's an inactivated influenza vaccine that can be offered at any stage of pregnancy. There's also the pertussis vaccine. The brand we're currently using is called Adacel, and that contains tetanus, diphtheria, and pertussis antigens, and that's usually offered around the time of the fetal anomaly scan, which I think is at 20 weeks. Is that right? Glad I got that bit right. And then more recently, introduced in September last year, is the RSV vaccine. The brand we're using is Abrysvo, and that's offered from the 28th week of pregnancy. So why do we offer vaccines in pregnancy? Well, there's a number of different reasons, and all of them are really quite important, because infectious diseases in pregnancy or infectious diseases in neonates can be serious and life-threatening. So we want to try and prevent maternal morbidity and mortality, and that's really important in the influenza programme. We want to try and prevent poor pregnancy and fetal outcomes, and again I'm thinking influenza here, because flu in pregnancy can have serious consequences, which we'll come on to in a moment. And importantly, we want to try and confer passive immunity to the baby to prevent disease during infancy. And I'm thinking all 3, flu, pertussis, and RSV infection for those. So we'll have a look at influenza first. And I'm sure you're all familiar with flu. You may be vaccinated yourselves against this during the autumn and winter. It's an acute respiratory viral infection. It's highly infectious, and it spreads rapidly in communities, particularly closed communities where there's close social contact, so hospitals, military barracks, care homes, families, things like that. It can cause a range of illness, so you can become severely ill with it, or you could have flu with mild or very minimal symptoms. But importantly, even if you've got very minimal symptoms, you can still be infectious to others. Trying to predict exactly when the flu or when flu activity will be at its highest is difficult. There are variations, but usually we see flu activity increasing from about mid-November each year, and typically it's going to peak in late December, but sometimes it can be January, February, and even later. Complications of flu, commonly things like bronchitis, otitis media in children, and sometimes secondary bacterial pneumonia. Less commonly, we can see meningitis, encephalitis, and primary influenza pneumonia. The risks of serious influenza infection are higher in children under the age of 6 months, in older people, in people with underlying health conditions such as chronic respiratory diseases and heart disease and neurological disorders and immunosuppression, and also in pregnant women. So particularly in late pregnancy, there's a higher risk of serious effects to maternal health, but at any stage in pregnancy, we know that those infections can result in perinatal mortality, prematurity, smaller neonatal size, and lower birth weight. So as I was saying earlier, in terms of maternal morbidity and mortality, we know that because of the changes to the woman's body in terms of decreased lung capacity and tidal volume in late pregnancy, increased oxygen consumption, and suppression of T cell activity, that actually this can make the woman in the later stages of pregnancy more at risk of severe disease, possibly requiring hospitalization and admission to ICU. There are some additional risk factors. So if the woman is obese or if they have diabetes, then that increases the risk of serious complications of influenza. And we know that influenza infection in pregnancy has poor outcomes, such as miscarriage, premature labour, and low birth weight. And in terms of the baby, once it's born, children under the age of 6 months have the highest consultation rates in general practice for influenza-like illnesses in the UK. So there's a range of different risks associated with influenza infection in pregnancy. This slide is from the Embrace report in 2023, and the line that I think is particularly interesting there is the green line, because this shows direct sepsis incidence associated with influenza, and you can see in 2010, 2011 it was quite high, and then over the years that's come down. Probably a number of different effects going on there. One of the effects might be vaccination in pregnancy, I hope. But the other effect there is, you recall that there was an influenza pandemic in 2009-10. We had the H1N1 virus, more commonly known as swine flu as well. So it might be that was having an effect around 2010, 2011. And it hasn't gone away. We still vaccinate against it. In terms of the effectiveness of flu vaccines in pregnancy, there's a number of different studies showing their positive effects. So vaccination halves the risk of infection with confirmed, halves the risk of infection with confirmed flu in pregnant women. It reduces the risk of prematurity and of low gestational weight. It provides passive immunity to the infant in the first few months of life, and therefore will lower by 63% the risk of laboratory confirmed influenza in infants. And it also, there is a significant reduction in fever, respiratory illness, and confirmed influenza in babies born to vaccinated mothers. So I think of this as a bit of a, almost like a triple effect. The vaccine can help protect the fetus and the baby as it's developing in the womb. It will help protect the mother, particularly in the later stages of pregnancy, and it also protects the baby once it's born because of the passive immunity that baby is born with. So I think there's a triple effect going on here from this vaccine, in contrast to pertussis and RSV, which we'll come on to in a moment. All important questions about the safety of inactivated influenza vaccines in pregnancy. There's a number of studies here, and the reason why we've included these are systematic reviews, so we're looking at large numbers of individuals in these studies. I'm not going to go through them all. I think you'll get copies of these slides, I believe, but the important point here is that these studies are large. We're talking about hundreds of thousands of pregnant women have been investigated, looking for ill effects associated with the influenza vaccine in pregnancy, and these studies are reassuring that beyond the usual side effects of a sore arm and a headache, that actually there are no known serious risks with receiving a inactivated influenza vaccine at any stage of pregnancy. So I think it's good that we've got this evidence and we can provide that reassurance to pregnant women. Influenza vaccine uptake in England has been quite variable, as you can see from this bar chart here. Lowest it ever was in 2011-2012, which is 27%. I think we got up to about 47% in the first, no, not in the first year. 2017, we were up to 47%. And then during COVID, actually, it stayed fairly high. We're talking about, sort of low to mid 40s, but there has been a bit of a drop off since then. I I do wonder, I suspect, whether or not a lack of confidence in the COVID vaccine might have impacted people's confidence in influenza and other vaccines given in pregnancy. And I think the other thing it's important to acknowledge here, it's actually quite difficult to gather this data because the denominator is constantly shifting. Women are becoming pregnant and then no longer pregnant all the way through the flu season. So it's actually quite difficult sometimes to gather this sort of data. But there's clearly a way to go to try and improve the number of women who accept this vaccine in pregnancy. I'm going to move on now to talk about pertussis, better known as whooping cough. This is not a virus, it's a bacterial infection caused by the bacteria Bordetella pertussis. It's highly contagious. It spreads very easily from person to person through droplet infection. And it does tend to be a bit cyclical. We'll see increases in the incidence of pertussis infections every 3 to 4 years. So the symptoms and the early symptoms are very similar to a cold, that you get this sort of catarrhal phase, and that progresses to intense bouts or paroxysms of coughing, often associated with an inspiratory whoop. Has anyone seen a case of whooping cough? Yeah. Yeah. I've never seen a case. There are videos of this sort of stuff on YouTube, and they're not comfortable viewing. It's not a nice thing to witness. The very young infants don't tend to whoop. They don't tend to have that inspiratory whoop. And you can get vomiting, and generally the symptoms last 2 to 6 weeks, but they can persist for some months. In terms of the complications in infants and young children, then we can see things like pneumonia, episodes of apnea, weight loss secondary to vomiting, seizures or brain damage, and encephalitis. And I think this is an important statistic here, that 90% of infants with whooping cough are going to require admission to hospital. And typically we see about 5 to 8 infant deaths in a typical year from whooping cough. And those of you who've been around in the world of either maternity care or immunisation and vaccination may recall that we had a peak in whooping cough cases in 2012. There were 14 infant deaths in England, but it's making a bit of a comeback, unfortunately. We've seen 11 deaths in 2024. So, those, was it 14 deaths in 2012? That was when we introduced an emergency program of maternal vaccination with pertussis-containing vaccines. I remember it very clearly as I was driving to work and I heard about it on the radio, and I thought, oh, that's going to be a really interesting day in work now, because everything I've had planned is going to go out the window and I need to get on and implement this for the area that I was working in. This graph is from that time. This is from 2011-2012, and it shows the cases of whooping cough by date of onset, by age of onset in weeks. And this is really important because you can see here most of the cases, the onset of the disease in these babies was before the routine immunisation program kicks in. So we vaccinate against whooping cough at 8, 12 and 16 weeks, and actually most of these are occurring before we can give baby that active immunity. So that was instrumental in sort of scientific thinking about, well, if we're going to vaccinate when all these cases are occurring here, we need to do something a bit different. And the thing that was considered was, do we do maternal vaccination, offer a vaccine in pregnancy, so that when the baby is born, it is born with passive immunity, the antibodies have transferred via the placenta to the baby. That will protect baby for the first few months of life until we can get baby fully established on the routine immunisation program, and we can start to promote active immunity through that. So that was the program that was introduced in 2012. The initial recommendation was that in every pregnancy a single dose of a pertussis-containing vaccine would be offered from 28 to 38 weeks. That was then changed in 2016. There was some research, I think, from Switzerland, which showed that it was safe but more effective if we actually offer it earlier in pregnancy. So that can be offered from 16 weeks gestation. But for operational reasons, it's normally offered just after the fetal anomaly scan. And the aim of the program is to boost antibodies in each pregnancy so that baby is born with passive immunity. And this is considered the most effective way of protecting babies from the moment they are born until we can vaccinate them routinely from 8 weeks of age. This graph shows the annual incidence of pertussis infection by age groups. And this is the blip I was talking about in 2012, and this is when we started the maternal vaccination program. And then you can see there from about 2020, 21, 22, very, very little pertussis activity going on. And this was because of all the social distancing measures and lockdowns that we saw during the COVID pandemic. And then in 24, it's come back with a vengeance. And that big green line is, which has got the highest incidence, is 10 to 14-year-olds. So we think these are adolescents that are driving the most number of cases. They've probably been vaccinated as kids, but unfortunately the vaccine protective effect is probably beginning to wane. It's probably wearing off as they hit their teenage years. And that's quite an important factor, actually. So we've got teenagers kind of the big reservoir of pertussis infection, but actually they're not going to die from it. It's actually the little babies. It's the newborn infants that we worry about the most. And in fact, the next highest incidence, the blue dotted line, is children under the age of 3 months. So those are the ones that we really want to protect through maternal vaccination. Oh, right, what's going on here? Right, okay, here we go. These show infant deaths from pertussis from 2001 until November last year. And again, you can see that big spike in 2012, which is when we started the vaccination program. And then that big spike on the right-hand side are the deaths that we've seen last year, unfortunately, from pertussis. We don't have published data yet on whether those mothers were vaccinated. That will come in due course. But you can see with some of these cases, between those 2 points, that there is some variability here. So we've got most of the cases are occurring in mothers who were not vaccinated. There were, I think, 2 cases or 2 deaths here and here where the mum had been vaccinated, but when we examined those in a bit more detail, actually they were vaccinated very, very close to the point of delivery. And that means that there isn't really time for the mum's immune system to generate enough antibodies and for those antibodies to transfer via the placenta and accumulate in the baby. So the timing of the vaccine is important as well. We need to try and not just improve uptake, but make sure that that uptake is happening around sort of the 20-week point. This is the uptake of pertussis vaccination in pregnancy, and as you can see, it's been quite variable. We had a low here, this blue dotted line, 2023. That might be a COVID effect. It might be, perhaps women felt less confident about vaccines in pregnancy. But the data for this year thus far, I think, is a bit more encouraging, and that suggests that actually we're on a more of an upwards trajectory with uptake, which is good. Again, important questions about the safety of any medicine in pregnancy. These studies, I'm not going to go through them all, but there was a study by Donegan, I think she worked for MHRA, that was published in the BMJ in 2014, found no risk of stillbirth or neonatal death or any of those sort of complications of pregnancy listed there associated with vaccines in pregnancy. This study here from Gayatri Mithalangam, who's one of my colleagues in UKHSA, again demonstrated the safety and efficacy of pertussis vaccines in pregnancy, and more recently a study by Lavity in 2021 found no increase of adverse childhood outcomes in babies born to pertussis vaccinated mothers in pregnancy. So in terms of the safety of these vaccines, there's increasing evidence that they are safe to give. In terms of the efficacy, I should have put this on that slide, over 90% efficacy in preventing pertussis infection if the mother was vaccinated at the optimum time in pregnancy. So it's definitely working. How am I doing for time? A little bit pushed. Right, okay, let's move on to RSV. So this is a thing called respiratory syncytial virus. Again, it's a highly communicable viral infection, transmits via droplets, common cause of winter respiratory tract infections. Over 60% of children are infected by their first birthday, and over 80% are infected by their second birthday. For most people, it's a mild and self-limiting respiratory illness in healthy adults and healthy children, but it can be severe in infants, and in particular, it can be severe in older adults because they're at risk of lower respiratory tract infections. It's a leading cause of infant mortality globally, and we think it results in about 20 to 30 deaths per year in the UK in infants. So it is a significant disease. I think it's been well recognised in infants over the years. I think it's been less recognised in adults because baby gets a respiratory infection so severe that they need to go to hospital. Someone's going to test them and try and find out, is it flu, is it RSV, is it something else? Probably less so in the elderly. They're probably less likely to be tested. In terms of complications, the major complication in infants is this condition called bronchiolitis. It's especially, or it's more prevalent in very young infants if they've been born prematurely, and if they've got heart or lung disease, or if they're immunodeficient. It's a common cause of hospitalization in children under the age of 1. And somewhere between 1% and 3% of babies with RSV infection require admission to hospital, and we think that equates to about 33,000 hospital admissions per year in children under the age of 5 years. They may need nasogastric feeding, they may need IV fluids, and they might need mechanical ventilation. I'm a former infection control nurse, and I can remember working at the General Infirmary in Leeds, and the paediatric wards would, often have large numbers of babies with RSV infections in the winter months, and they'd run out of side rooms to put them in, so you'd just put them in a big cohort. If you knew that they were all infected with RSV, then they would be managed in a kind of big bay full of RSV infected babies. So in September 2023, this body called the JCVI, this is the Joint Committee on Vaccination and Immunisation. They are an expert advisory body to the Department of Health, and they reviewed the evidence, and they looked at the available vaccines, and they looked to see how these were being used overseas, and they recommended that we introduce an RSV vaccination program in the UK. That was launched in September 2024, so we offer a single dose of RSV vaccine from 28 weeks of pregnancy or soon after, and it should be offered in each and every pregnancy, including to those under the age of 18 years. And the aim is to reduce the incidence and severity of RSV disease and hospitalization through immunization. And rather like the pertussis vaccination program, what we're trying to do is boost maternal antibodies to RSV, so they are then passed to baby, and that will provide passive protection to infants in the first few months of life. Thank you. The RSV vaccine is not given to infants or young children. It is absolutely contraindicated in infants and young children because if they subsequently get RSV infection, there's this weird immunological effect where they actually get enhanced disease. They will be sicker, unfortunately. So the way forward here is to provide passive immunity through vaccination and pregnancy. If there are infants who require protection against RSV infection, maybe they've got heart disease or lung disease, then there are monoclonal antibodies that can protect them, but we don't offer a vaccine to them. It is effective. In the interest of time, I'm not going to go through all of this, but I think the key headline figures are down here. That vaccine effectiveness against severe RSV, lower respiratory tract infection, was 82% at 3 months, and it was 57% at 90 days. So it is an effective vaccine, without a doubt. There have been a number of different studies. I think this vaccine is a little bit different to flu and pertussis because this vaccine, when it was going through clinical trials, was actually trialled in pregnant women, 4,000 pregnant women. And the most commonly reported side effects were things like injection site pain, muscle aching, headache, and things like that. These are quite common side effects after any vaccine. There were slightly more premature births in the vaccine group compared to the unvaccinated group. It wasn't statistically significant, and there was no temporal association there. So we think that was probably just a little bit of an anomaly in the data. But MHRA, as they do with all medicines, will be undertaking or continue to undertake surveillance of medicines safety. And it's been used in the USA as well, and that's showing good efficacy. In terms of uptake, this is some quite early data. So in the 5th month of the program, which was January this year, we had uptake of 53%. So not as good as pertussis, but better than flu. And I think these are early days, and I think we can improve on that. There does appear to be some sort of gradients in vaccine uptake. So we can see here that in the southeast of England, uptake was highest at 62% and lowest in London. And also there also appears to be some differences in ethnicity, with black and black British and Caribbean mothers having the lowest vaccine uptake of 28%. So but I've run out of time, going to move on and talk about parental attitudes and attitudes of pregnant women towards vaccination during pregnancy. I think I'm at time, aren't I, by the look of it? Right, okay. So I will stop there. Thank you. I will stop there. I do believe these slides are shared with the delegates, so you will be able to see the data that I was going to present. In terms of questions, we can either take them now if there's time, or I'll be out there on my stand if anyone's got any questions that they want to come and ask me. So thank you very much for listening.
Okay, thank you. That's very interesting.
Cheers. Thank you.
That's an interesting piece as well.
It is, yes.
So I look
Yes.
forward to seeing that. Thank you, everybody. Tea time now. Enjoy.
Okay, thank you.